Let me introduce Dr. Anja Pinborg from Copenhagen University Hospital. She's going to talk about IVF against IUI. What should we choose and when?
Is the microphone working? Yes, it is. Thank you, and good afternoon, ladies and gentlemen. And I want to start with thanking again Emilia and Rita for this excellent conference. I'm very pleased to be invited to give a lecture here. And I feel a little bit in the same boat as Ursula, because it's also my first time speaking at a session on male factor infertility. So please forgive me. I will try to do it evidence-based, with a little bit of common sense, but also maybe with a little bit of feelings, and I will explain that. It's why, or conflict of interest, or what you will say, but it's why we in Denmark have a long tradition of intrauterine insemination. So that's my conflict of interest this afternoon. So my talk will be about when to use IUI and when to use IVF. I thought that would be a very easy talk to do, but digging into the literature, I realized that this is a challenge. We want to have treatments for our patients, or our patients want treatments that are simple, reliable, safe, less expensive, and non-invasive. But are they also cost-effective? And that is the big question here. So the content will be about when we use IUI in unexplained infertility, mild male factor infertility, and then the last part of my talk will be about the Danish experience, where we have looked into cumulative live birth rates after intrauterine inseminations since 2007. So this year, in 2018, a recommendation was published in Human Reproduction Update. It was a systematic, went through all the evidence on IUI, and they made 20 recommendations, and this is a WHO guidance also for implementation of IUI. I think this is a very sensible, reasonable paper, so if you want more information, then look into this paper. Then to unexplained infertility and IUI, patients with a good prognosis. I have to mention the NICE guidelines. You're probably all familiar with those published in 2013. To many people's, many people were a bit were discussing this paper because they actually recommended that IUI should not be routinely offered for unexplained infertility, mild endometriosis, or mild male factor infertility. This is obviously the indications that are used for IUI in many countries. And then they went further on that they said that IVF should be considered at first-line treatment after 2 years of expectant management. And this was based on a mathematical model published in 2006. A year after, there was a survey published based on a survey sent to most fertility clinics in the UK, including 46 UK clinics, and the response rate was 70%. And it indicated that only 4% of the UK doctors were actually following the NICE guidelines. So something is in between the NICE guidelines and what people actually do. And there are also many patient surveys saying that patients accept actually IUI. So I will shortly go through the literature. In 2008, and I discussed this randomized control trial yesterday with Professor Bhattacharya, they published a randomized control trial where they examined live birth in unstimulated IUI versus expectant management. And I have to emphasize here that it was unstimulated IUI. They found here an odds ratio of 1.453 with a confidence interval from 0.9 to 2.56, with almost 200 in each arm. But still, if you look, it wasn't significant, but if you look at the odds ratio, it was 1.5. After that, there has been a Cochrane review in 2012, including the 14 trials on this, saying an odds ratio of 1.6, and again, statistically insignificant, but still an odds ratio of 1.6. What they conclude in the Cochrane review is that no conclusive evidence of a difference in live birth or multiple pregnancy comparing IUI with timed intercourse. And this is course in patients with a rather good fertility prognosis. So, there was this published debate in 2016 also that it's high time to provide proper scientific evidence for the effectiveness of IUI in comparison with expectant management. And that is still, I underline, with unstimulated IUI. Then I go back to male factor infertility, and I will come back to stimulated IUI. With male factor infertility, there is a lack of consensus also in the definition of mild, moderate, and severe male factor, and there's also a lack of consensus regarding the lower threshold of sperm count when you do IUI versus ICSI. But in the recommendation made this year, based on the studies by Van Waard and Ombelet, they say that around a total motile sperm count of 3 to 10 million, 0.525 total motile sperm count after sperm wash. In Denmark, we use 2 to 5 million progressive motile sperms per milliliter before we do ICSI, and a normal sperm morphology of more than 4%. So these are the reasonable limits for doing IUI, lower thresholds for IUI. Let me come back to then IUI regarding ovarian stimulation. There is this randomized control trial published in BMJ in 2015, and that's probably the best evidence that we get in this area. They have compared with 200 patients in each group 3 cycles of IVF with single embryo transfer and the added frozen transfer cycles, with 6 cycles of IVF in modified natural cycle and 6 cycles of IUI with stimulation, ovarian stimulation. And they found comparable live birth rates, 52, 53, and 47, in those 3 arms, with multiple pregnancy rates of very reasonable size, 5 to 7% in all the groups, based, of course, I'll come back to that, to very reasonable cancellation or conversion criteria. They also found that there was no inferiority of IVF, the single embryo transfer, IVF in modified natural cycle, to IUI in this group of unexpected or mild male factor infertility. And that is, of course, bear in mind with ovarian stimulation. So IUI and ovarian stimulation was in the recommendation set that we should aim for ovarian stimulation in reasonable, like with gonadotrophin, 75 units, with clomiphene, 100 milligrams per day. The pregnancy rates after 2 follicles were developed compared to monofollicular growth was increased the pregnancy rate with 1.6 in the odds ratio. And if you had more follicles, you also increased even more the pregnancy rate, but of course with a high risk of multiple pregnancy as a risk factor. So in unexplained, they concluded and recommended in the Cochrane review that with IUI, with ovarian stimulation versus IUI alone, there's a 2-fold increased chance of pregnancy based on 400 patients. And then we have the FARCO study published in Lancet and presented at the ESRA Congress last year in 2017 in Geneva, looking at IUI plus clomiphene citrate versus expectant management, also in unexplained infertility with a moderate prognosis. And they found that the cumulative live birth rates, and remember this is, or I will have to underline that this is cumulative live birth rate, and odds ratio of 3.4 with IUI with the clomiphene citrate versus expectant management. So the newest study. So IUI and ovarian stimulation in these recommendations from this year says that at least in couples with unexplained infertility without male factor infertility, we should use ovarian stimulation. It's still debatable whether IUI plus ovarian stimulation should be used in mild male factor or that we could use IUI alone. But I think using slight doses of gonadotrophins or clomiphene here is still possible if you just stick to the cancellation or conversion rules, guidelines. And then we have the big question, and we are always discussing this about what do we do with the older age women, women in their late 30s or women above 40. Is it better to do IUI and IVF? And I'm afraid I don't have the answer. I think it has very much to do what we do about reimbursement rules. When we go down to basics, we think that in these women we mostly can have few eggs out, so it's possible that it's better to keep them in the female body. But we don't have the literature to underline this. So I think in this group it could maybe depend a little bit on the reimbursement rules. If in Denmark, where we have only reimbursed IVF up to 40, we are a little bit turning towards doing IVF when the woman is turning 39 years and a half, because we know her time for reimbursed IVF is limited. But we don't know as yet whether one or the other treatment is cost effective. Then just finally, before I turn to our own experiences, multiple birth rates. I think with reasonable cancellation rules or conversion to oocyte pickups, we can see here, based on register data and on a Dutch study, that there are 9% multiple birth rates after IUI. But with even stricter rules, I think, and the FARCOS study where they had very strict rules, I'm coming to that, ended up with a multiple birth rate, which I think is acceptable, from 5 to 7%. And they used these cancellation rules, that cancellation or oocyte aspiration should be done if 3 or more follicles of more than 50 millimeters is there. If you go further up, say you accept 3, then you will have a twin birth rate of around 10%. But if you go down to only 2, you will have twin birth rates lingering around 5%. And if you have more than 5 follicles of more than 5 millimeters. And that's also what is written in the recommendations this year. So now let me turn to the results of our own study, which is based on the Danish register data from 2007. This is, they have in the FARCOS study also looked at cumulative live birth rates, and we did that too in this study. Traditionally, and I think we should not only look at cumulative live birth rates. I think it's very important that we have more parameters measuring the success after fertility treatments. So to try and find one very good tool of assessing ART success is not possible if you will describe the whole picture. So, but we need also cumulative live birth rates, also in IUI. So just the basic information about how things are in Denmark regarding IUI. All IUI treatments are reimbursed, but we have national guidelines indicating that 3 to 4 IUI should be performed, not more, in patients with mild male factor infertility or unexplained infertility, up to 6 in patients with anovulatory infertility. The couples can have no common children if they should be reimbursed, and women should be less than 40 years of age. So that's just the context we are in. We have we usually do IUI in mild to moderate male factor infertility and in unexplained infertility. And here's the trajectory of a couple where they start with IUI. We were able to follow them also converting to other kinds of treatments. So this is an example of a couple starting with 3 IUI cycles, then going according to the national guidelines towards IVF, and then they finally conceived by frozen embryo transfer cycle. Another example is a couple going through 2 IUIs and then to natural conceptions. And I will now guide you through the results from this study. We looked at live birth in the medical birth register, and we were able to cross-link all the data, and so it's a national study, 2, 3, and 5 years after initiating of the first treatment. We looked at treatment-related conceptions, but also on natural conceptions. And women were all followed until their first live birth, and then they were censored out of the study. So the cohort was subdivided in all the couples starting with IUI and all the couples starting with ART. And of course, those starting with ART is another group. They have a little bit longer time to fertility, and there's more severe male factor and tubal factor infertility in that group. So you can say the prognosis would be a bit less good in that group. We looked at and stratified data according to type of conception and according to female age at initiation of treatment. And the results here, and I think it's also fair to say that 92% of all treatments occurred within 2 years after the first treatment. So people are not hold on in a system for 10 years. Above 90% end the treatment within 2 years. So here are the results of the overall, where we looked at both ART-initiated treatments and IUI-initiated treatment. And the long-term prognosis, and bear in mind this is national data, was 71%. So after 5 years initiating fertility treatment in Denmark, 71% end up with a live birth. 80% of the women couples where women were aged less than 35 years, and only 26%, 1/4, in women aged more than 40 years. And that is, of course, expected. 47 conceived after treatment, and 14 conceived naturally. So the median number of total fertility treatments was 3, not an expressive high number. And 49% had a total, almost 50% of the cohort had a total of 1 to 3 IUI treatment, whereas 38% shifted to ART. And here are the results, and I think this is probably the most interesting slide. This is the couple starting with IUI treatments. And in this cohort of moderate to good prognosis patients, 75% conceive in all age group overall after 5 years. But see here that more than 1/3 actually conceived after IUI. So we can actually skip 1/3 of the cohort, not going further to IVF. So 1/3 of a population of 20,000 women can actually be pregnant after IUI treatment without going further to ART. And in the total cohort, 24% conceived after ART, 14% after natural conception. And here are the age-stratified results. In the IUI starting group, those starting with IUI from the beginning, 83% actually ended up with a live birth within 5 years. And 65% within the 35 to 39-year-old group, and above 40, 31% ended up with a live birth. And it's more than when you look at those couples starting with ART. They are, of course, a less good prognosis patients. All the rates are almost 10% lower than in the IUI initiating group. So, of course, those starting with IUI has a better prognosis. But we can also sort 1/3 of the couples off by using an IUI strategy. So my conclusion or discussion here is that 35% gave birth after IUI within 2 years. It's less invasive, it's less expensive, and it's patient-friendly. So overall, based on our results and the results from the evidence-based, a little bit common sense and a little bit of feelings also, because it's difficult in a tradition to stick to other things, but I think that it's fair to say, reasonable to say, that IUI can be used for unexplained plus male factor infertility. Ovarian stimulation plus IUI needs to be done in unexplained infertility to have success. The number of IUI cycles is still questionable, but a number between 3 and 6, probably 3 to 4 in unexplained infertility and mild make factor. Clomiphene citrate and tamoxifen can be used, or gonadotropins in doses up to 75 units, dependent, of course, on the age of the woman and the prognosis overall. And probably gonadotropin are a little more efficient, but also gives higher multiple birth rate if you are not careful by having strict cancellation or oocyte pickup criteria. Close ultrasound is, of course, dementrial in IUI cycles now to avoid multiple pregnancies. In women above 40 or around 40, it's still questionable what is more efficient. And the lower sperm count threshold is also still debatable. So thank you very much for your attention.
Okay, we have time for some questions.
Yes.
One.
But I think people can hear me. It was a very balanced representation of what we actually have in front of us. The only thing perhaps that I would like to add is I think you're being a bit too reticent about the over 40s, because although the evidence base isn't strong, there actually is some evidence from the FAST trial. This is Goldman et al. 2014. And although the sample size is quite small, what they showed was that the group that went straight to IVF had a higher chance of conception over the next predetermined period of time. But the interesting thing then is to bring in what Bashian did in 2006 and to model the costs of what it would take to get the people who didn't get pregnant over that period of time with IUI to get pregnant through IVF. Because that's the problem in the over 40s. Would you agree with that?
Yeah, I agree with that. Thank you very much for adding this comment. And time to life birth, I didn't touch upon that. That's, of course, also for the couples a very important parameter. And I don't think there are very many studies on time to life birth. But in our cumulative study, we can see that 90% actually has finished their treatments after 2 years, even if they start with IUI. So, but thank you for adding this.
Thanks.
Another question?